So that is that. Before starting taking history, you need to introduce yourself and gain consent. You can ask, do you feel well enough to talk now? Check if there is anyone present that makes the patient uncomfortable. That is a common sense aspect. Then you start on preliminary data. Start by full name. The preliminary data is just the same as the biodata. So what you talk about here is the configuration of the information available to the patient. So that is the the biological data. That is what we call the biodata. So we're gonna have the full name as first one. So the name. Although a simple question, it's very important to ask about the name of your patient to be familiar with the patient. Also for identification and for registration. Remember hospital, if anything, if nothing is recorded, eventually you'll say nothing happened. So everything must record, including the name. Sometimes the name helps us to know the nationality. And why should you know about the nationality? Yeah, that one will help us also to talk about the what we call the epidemiology. Yeah, there's some disease affecting this kind of national, the race and all that. An African and white mass person, that is so different in a way. Another thing is religion and sex of the patient. Usually it's possible, for example, to differentiate between Japanese and Chinese names. So by that, you will just quickly click on what is there. This one can also help you a lot because some diseases are common in Japan and not in China and vice versa. So names like Muhammad and Ahmed are very common in the Islamic world. A female Muslim patient should always be examined by a female examiner if possible, because that is what their culture dictates. So never forget patient's name, because that one also will indicate how serious you are with the patient. So the patient will always note these minor things, and if you happen to forget the patient's name, then it always gives like some sort of ignorance, so maybe you are not undertaking their issues in a serious way. Age. The importance of asking about age is that certain diseases have high prevalence rates among certain age groups. Then you have sex. Sex also is very important as one of the biological data or the biodata. Sex, like for example, the systemic lupus erythematosus is a common in female, while peptic ulcer is common in male. So if you know sex, you'll know the disease that affect that specific gender or sex. We still go on well. Let's check on the residential address. So when you talk about residential address, different areas got different conditions or maybe disease which affect those people. Depending on the geographical relationship. Like people are staying at a specific area, like there are endemic diseases in many places around the world, like bilharzia in Egypt and leprosy in some part of the India. So when somebody tells you where he or she stays at, that is now easy to narrow on your diagnosis, because you are obviously thinking of specific disease affect those people. Why do we ask about address? For follow-up, possibility for emergency, and quick attendance to the hospital. That is. Another thing is occupation. Some jobs are predisposing factor for varicose veins and hernias. I'm just telling these are not the only thing. Predisposing in a way that the job give a patient a tendency, or it enhances the probability of the disease to affect the patient. That is, for instance, when you're doing a kind of a job which is strenuous, you definitely develop some either muscle conditions or bone conditions. So like the job some job can cause varicose veins, hernias, which are more common if the patient lift heavy objects in the work. So by knowing the occupation, you'll actually narrow on your diagnosis. Mine workers have risk factor of pneumoconiosis. Ask the patient about any second job or previous job too, because that one can also have influence the entire perspective of the patient. What job have you done the longest? There's a question. You can ask that one as well. Marital status is another thing in the biodata. So are you single or married, divorced or widow? So you need to ask, since how long have you been single, or so that you can know. This one and are related to psychological problems. So for instance, single patients who are breastfeeding, maybe a single patient who are taking care of their siblings on an independent note, tend to have a lot of psychological problems because of the financial depression and all that. So ask about the number of children, the age of the last one too, so that you can know the status of the patient in terms of the psychological opinion. Ask about the nationality, place of the birth and origin as well. Another thing, date of admission and time of admission. For example, that is for inpatient. Inpatient to mean admission last one than your word. So talk about the date of admission and time of admission as well. Away from that one, blood group, right-handed or left-handed. You can also note that one. If limbs or the muscle system are involved in the disease, also ask about that. So blood group is also a key thing. That one you need to know. I'm sorry, just drop on what I was. So blood group, that is that. So name of the number 10, the 10th part of biodata. You need to name the name of a patient, general practitioner, contact information for possible consultations. So you need to know the name of patients or general practitioner and contact information for possible consultation. So general practitioner, GP just like a family doctor who has been very close proximity to the patient's condition. So he is having a detail about the condition from the beginning, the pathogenesis, and the progress. So for this one, at least you can contact for information, and then you can also consult in the previous state of the patient. So now tell the patient's data in one paragraph. You need to be able to tell, that is especially when you're doing assessment and you're presenting your history. You start by the name, age. So the only part of the biodata or personal data which is very crude is the follow, what you're able to see from your screen: name, age, sex, location. Yeah, this is completely wrong. You should tell it like a story. You don't just like name, David Omutieno, age, blah blah blah, sex, male, location, blah blah. So like in such a situation, you don't need it. You just need to come on clean. David Omutieno, blah blah blah, age, sex, blah 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 blah. Like, so you don't need to mention age. So let me use a family name, because if I use my David, you'll be like, oh, David is this solo shit. So this is what is necessary. You can say Godwin Makachola, age 24 years old, male, patient from Undanyi, presented. You see, you've already clocked, like you've given out the details in one frame of a paragraph. You don't need to break it down. Another aspect. Now, for example, Mr. John Adams, 29 years old, man, British patient from London, is a teacher, married married since 5 years and father of 2 children. The youngest is 2 years old. His blood group is O positive. He is not a smoker. Admitted to hospital on 3rd of January, 7 p.m., complaining of recurrent abdominal pain or happening for the first time. Kind of this shit, you see? So then the chief complaint is now next part of the general history taking of the clerkship. So it's the problem that has prompted the patient to request the consultation. That means what has necessitated the visitation of the patient to the hospital or to the facility. So you need to be, immediately you do all that, the personal data, and you're done. You come and now start on the chief complaint. Chief complaint is what the patient has brought, or what complaint has necessitated the arrival of the patient in the clinic. So the way of asking about the chief complaint, like first, try to encourage the patient to talk by asking him more open-ended question, because this gives the patient the opportunity to talk about any oral problems. Another aspect, that you need to close direct question like yes, no question. They need to communicate the patient should remain silent until asked a specific question. Get me right. Close direct question like yes or no question mostly should be avoided. So, but then you can use them at some aspect. Yeah. So you also supposed to inform the patient to be silent until asked specific question. But when you're using open-ended question, ask for narrative information. Instantly, open-ended question give the patients a variety of perspective, or maybe chances to speak everything about the condition. So closed question asks for specific information, while open-ended question give out narrative information. Closed question, for example, it gives you, did you go to the, okay, let me for instance give you, do you have headache in the morning or at night? So that one is closed because it's either in the morning or night. And the open-ended question now comes in like, at what time do you always have the headache? So this one gives the patient give you narrative information. Let the patient talk without interruption, and a study by that guy and that guy show that physicians eager to arrive at clinical diagnosis would interrupt the patient within 18 seconds of the patient beginning to speak. They found that the patient rarely continued to express their true concern once they were interrupted. So you just need to listen first. Listen, do the listen. Culture of listening is very perfect in terms of that one. Clerkship. So chief complaint or present complaint, whatever. Chief complaint can also be called present complaint. It's wrong. What is wrong with you? What brought you to see the doctor? The most disturbing complaint, the patient has many complaints. That is, you need to ask the patient in a simple way. That's what we call chief complaint. What is wrong with you? What brought you to see the doctor? Yeah. So when the patient has got many problems, a problem actually is just a problem even to you. If the patient has many complaints, but then you just need to cover it. So mention the complaint the patient's own words, like no medical term should be added. So don't say dyspnea. I know dyspnea is difficult in breathing, but you don't say dyspnea. Rather say breathlessness. Yeah, it's understandable. Vomiting blood, don't say hematomesis. Instead, just say vomiting up blood. When you're writing down the chief complaint, use the patient's word. Nilitapika damu anzia wiki uliopita. Don't say the patient had hematomesis for a period of 7/7, just say 1 week. So never mind. The reality is, use the patient's one. No patient will come and tell you about hematomesis, yeah, or sort of dyspnea. So you just have to do that. Another aspect, that if there are more than one symptom, mention them in chronological order with duration. For example, abdominal pain since 7 days, vomiting since 4 days, fever since 2 days. Yeah, that is if there are more. So you need to say from the starting, the condition we started. Like you see, 742, the most earliest one was abdominal pain 7 days ago. So you can use the symbols like 7 days ago will be 7/7, right? You need to know that. So if the patient has multiple complaints, you need to mention the last time the patient was in his or last usual state of health. So that one, it's always included in the history of presenting illness, but it's also good to mention them in chief complaint. Then you need to analyze of chief complaint, like presenting complaints, a description of development of the illness. So in analysis of chief complaint, you should use medical terms. That is when you're analyzing. So instead of using those now patient's word, when you analyze, use medical terms, like you are now evaluating it. But of course, not when talking with the patient. When you are presenting it is when you use medical term, but when you are talking with the patient, you use his own word or her own word. So when you're analyzing, you talk of mode of onset, sudden, acute, subacute, gradual. Sudden is like, if it is headache, it just appears to exist. Acute is very intense and just at once. Subacute is more of gradual but also acute in a way. Then gradual as lasting by some bits, showing up, disappearing, sort of. That is. Duration and frequency is another thing. Duration and frequency comes to play. So yeah, so we have acronyms to help you in taking care of this analysis. Okay, so you can ask when, duration, when did it start, frequency, how often do you feel it, site. Mention the site exactly, like localized or diffuse. Diffuse to mean that it moves from one region to another. Localized, it is just within the same place. So if it is diffuse, where is the maximum site? Where did it start? See. Aggravating factors and relieving factor. What makes symptoms worse? What makes them better? Let the patient talk about his aggravating factor. Aggravating factor ni kitu inaongeza uchungu ama kitu inapunguza uchungu. So that is that. Another thing, cause of symptoms: progressive, retrogressive, constant, periodic, stationary, or fluctuating. Progressive, in terms of it continue. Retrogressive, it goes back. Constant, it just maintain a period. Periodic is within sometimes it disappears. Stationary, it does initiate. It stand by in a stationary way. Fluctuating can be low, it can be high. Do you know variation, like fever and tuberculosis, which are specific to peak mainly at night? So do you know terms of nighttime elevation, and it can be low during the daytime. They talk about the seasonal variation as well. Many respiratory condition comes with the seasonal variation. Now severity, like severity, intensity. In class of intensity, you talk about severity of the condition, like when the condition is highly felt. Let me admit other people in the class. That is what we mean by severity. Severity, you can use a scale from 1 to 10. Then you do not describe the scale and do not give example. Just let the patient give you a number. I want you to be clear here. Sometimes we do mess. The patient can be very, very excited or maybe surprised by what you mean by, can you grade for me? Naambia mgonjwa, jinsi unavyohisi maumivu, nieleze kupitia mizani ya 1 mpaka 10. And then you start now giving out again explanation. Moja kama ni sawa, mbili kama ni sawa lakini si sana, tatu. That is no. Don't try to describe the scale. Just tell them out of 1, out of 5, out of 10. How do you range your pain? Muulize tu hivyo. Kwa kundi la 5, wapi ya saa wahisi? I don't know in Kiswahili, but what is there? Yeah, actually I don't even dream of being employed in like Tanzania, but yeah. So you let the patient give you a number. Like just yesterday there was a patient who had back pain in the clinic there, and it was like obvious. I had to use the scale for me to analyze the pain as a chief complaint. So you ask the patient that, can you scale for me your pain in the scale of 5? Then the patient keeps on looking at you. It's tricky anyway, but you just find out to maneuver. Character is another case. Character of pain, sputum, vomiting, and discharge. They need the character, and you are going to check them later in HPI. That is history of presenting illness. Pain, you must give it a character. Yeah, is it throbbing? Is it pounding? Sputum as well. The sputum can be yellow in color, can be red in color. Then vomiting, can talk about projectile vomit. Yeah, non-projectile vomit. And all that. Is it vomit with blood, hematomesis, all that? Discharge, vaginal discharge is an example of discharge. You can talk about the mucoid discharge, you can talk about the yellow discharge, the character of the discharge. More likely of like appearance, but that is. Radiation is another case which you can use to analyze on the chief complaint. So the extension of pain to another site, was the initial pain persistent. The ratio of epigastric pain to the back is up. So like how the pain moves from one place to another. That's what called it radiates. It moves from one place to another. Yeah. So you can also avoid confusing it with what we refer to as the referred pain, because for the referred pain, for example, the pain in umbilicus from appendix. The pain you feel it as if it's from umbilicus, but it's just from appendix. Radiation is for sure. Epigastric pain will be moving from epigastric region to the back in some patient with pancreatitis. So it moves, it just radiates to that region, but it does not come from that region. It radiates, it moves from where it was to that region. Associated symptoms, like following 5 constitutional symptoms, just put them there, like 5 of them. Like for instance, fever, or what we call the pyrexia. Ask about the grade. If it is low grade fever, that is less than 38.5. High grade fever, that is 38.5. More than 38.5. You also need to ask about the character of fever. Is it continuous, the same level throughout the day, remittent or fluctuatant but not reaching the baseline, intermittent, that is fluctuatant but reaching the baseline, or relapsing, which with long intervals of fever-free periods. Weight changes. Significant weight loss is more than 10% within 6 months. Severe weight loss is called cachexia, that the patient measure his or her weight. That is, now when we talk about the weight loss, you need to consider more than 10% within 6 months. That is called significant weight loss, or what we call the severe weight loss, which can also be called the cachexia. And on the same thing, weight changes can talk about that the patient measure his or her weight, that the patient follows specific diet to lose weight, did the clothes become wider over certain. So those are just few remarks that can help you also to denote character or maybe significance of the weight changes. Appetite. Anorexia is loss of desire to eat. Anorexia, that is. So you can have, and you indicate by writing anorexia. So anorexia should be differentiated from fear of eating, which can happen in gastric or gastric peptic ulcers, because the patient fears to eat because of that state of, after eating I'll feel the pain, the gastric pain. So anorexia, you just don't have the appetite, what you call the appetite to eat. You can still talk about sweating, fatigability, kuchoka haraka. Yeah, that is. Then effects and impaction of symptoms on patient's life. Talk about if you are used to travel by foot, how often do you now travel after the scenario? Yeah, you talk about that. If the patient had a trauma and the hand is like fractured, you again can consider asking, do you write nowadays as you used before, so that you can at least conclude on the effects and imperfections symptoms of patient's life. Sleep. Does the symptoms wake the patient up from the sleep? Daily activity. Does the patient need an assistant, job, or study? How many days the patient off for the job school? Analyze and investigation done so far, and their results, response, treatment, if any. Now, sitting. Where were you when you first felt ill? What were you doing? Who was with you? Those are just the investigation, as in the middle of, maybe when, after you've already known the chief complaint, or maybe let's say the chief complaint is surgical in a way, so alivunjika mguu, so you have to collect the data around the scenario so that at least you can have a solid vindication. This is the mnemonic which is greatly used, and that is all that we've described so far, the sawdust scares, or what we call the Socrates. Let me admit someone. So that is that, yeah. Kindly mute your microphone, please, if you've already arrived. Just mute your microphone. Good. Okay, that is that. Let's proceed. So I was telling you that we have a mnemonic called sawdust scares. So that is S for site, onset, duration, aggravating factors, relieving factors. So there is there the sawdust scare Socrates. The sawdust scare. And then you can also use Socrates. So Socrates still will give you the same. But now soda is kind of detailed than Socrates because there are more words to give you facts. So that is that. You can include any important past medical, surgical, personal, social history data which are strongly related to the chief complaint in the analysis of the chief complaint. So I'm talking, if you are analyzing the chief complaint, let's say the chief complaint was affecting the musculoskeletal system. So you need to bring on the past medical history on the same system, surgical on the same system. You analyze to detail. So you need to exhaust the details of the affected system. Then you summarizing the history of present illness, analyze of chief complaint in front of the patient is very important and very significant. So the summary gives the patient a chance to correct any mistakes in the history or in any misunderstanding if there is any. Now let's take a quick example of analysis of chief complaint. The patient was completely well 2 weeks. This is now you're analyzing. Example, this is an example. Let's take a quick example of analysis of a chief complaint. So the patient was completely well 2 weeks back when she suddenly started complaining of severe breathlessness along with cough. The breathlessness is aggravated by dust and cold weather with no obvious relieving factor. The cough is productive with green sputum and occurs approximately every 1 hour. Otherwise, his breathing is normal. This is the first occurrence of the symptoms that the dinner is history of asthma. So that is an example of that. So you need to always rely stories in days before admission. For example, 1 week before admission, the patient was blah blah. So you need to start by some when the patient was away from the hospital, or maybe where the patient was well. Taking history of pain. So I'm talking about the pain in this case. Now, in pain is an unpleasant sensation. Is a symptom in a way. So tenderness is pain on touch, and it is a sign, not a symptom. The patient feels pain. The doctor elicits tenderness. So you cannot elicit pain. Site of pain is one thing. You still use sawdust scares or Socrates. So site of pain, very important for making a diagnosis like epigastric pain. Right? Onset, sudden, gradual, etc. Vile ilianza. Duration, some diseases have a pain of very short duration, e.g. for second, like intrageminal neuralgia. Many other diseases have a pain of much longer duration. If the pain is chronic and the patient was living with it, or the patient brought you to see the doctor, because the patient was initially living well with the pain. Frequency, periodicity, and time of occurrence. Pain of peptic ulcer is a periodical and sometimes comes with a seasonal interval for few weeks or months on and off. So headaches that is more intense in the earlier morning can be sometimes an indicative of increased intracranial pressure, ECP, and I hope you know that. For aggravating and relieving factors, usually you need to see the pain in the musculoskeletal is aggravated by movement of the body part affected, and then the GIT disease are aggravated by food. So if there's pain in the gastrointestinal tract, it will always aggravated. So if the patient says that the pain increases while I'm eating, then just narrow it to GIT disease. Talk about when the patient is feeling the pain while walking, that is musculoskeletal. Some patients bend their trunks forward to relieve the pain of their pancreatitis. So if it is pancreatitis, then that is the case. Alkali antacid relieving pain of mild peptic ulcer. So the patient feels okay after taking antacids of alkali. You say that is mild peptic ulcer. Severity of pain is another thing to talk when you're discussing pain. To know the severity of pain, you need to ask the patient about his interference with his or her daily life. Activity and sleep. Does the pain wake the patient up at night or stop him from going to sleep? And other patient try to take analgesic, and the patient give a rating from 1 to 10 explaining the severity of his or her pain, and does not do not explain the rating, you as a clinician. So character of a pain can be burning. You see, we are socratizing all this. So burning pain, like in the series of inflamed urinary tract, dragging pain in an organomegaly, like in splenomegaly or scrotal swelling, etc. Those are so significant. Stabbing pain as well, like the pain in the peptic ulcer, which the patient can point out with one finger. Throbbing pain in abscess, tearing pain, like in aortic aneurysm rupture. All that ones so good too. Dull aching pain, the patient cannot describe this pain and usually say just pain, doctor. That is dull aching pain. Then colic pain has two features. One, comes and goes in sinusoidal way. Two, felt it like migrating constriction in a wall of hollow tube in attempt to push the contents forward. Another thing is constricting pain, also called crushing tight pressing. It might happen in angina pectoris. The extension pain, pain from an encyscal organ that has a restricting capsular wall, like bladder, bowel, encapsulated tumor as well, can get distension pain. Another idea here is pinprick pain in a paresthesia. Imekudunga mara moja nikatoka. Boring pain, like in bone pain. Chest tightness or heaviness is a term that could be used to patient to describe a pain or a character of a pain. Pain is sometimes nerve is well localized. So we have a very noble content. We still know to know radiation is feeling of pain in another area. This pain is continuous. This pain is continuous, and with the area of maximum intensity of pain, while referred pain is feeling the pain in an area away from the area of maximum intense pain. You can still go to medical students and under level for check on Clerckship and then general Clerckship, and then download this note. They're all there. Associated symptoms. Did you notice anything else? Severe pain can be associated with pallor, sweating, vomiting, and even rise in pulse rate. Migraine may be preceded by visual disturbance and vomiting as well. Of course, like any symptoms, investigation done, respond to treatment if any, and impaction on the patient's life. Transitional statement before the review of system. Prepare your patient for the coming question by saying, now I'd like to ask you some question about other parts of your body. Then begin the review of system with an open-ended question such as, do you have any other problems? And by the review of the system, we are aiming to 1. Look for complication of the disease on other system. Discover other symptoms which may be related to the current disease or other yet unknown disease. Knowing the presence of other symptoms can be very helpful, like anemia for anesthesia doctor. To discover side effect of drugs currently used by the patient as well. And then you also need to start the review of system by the most relevant system. For example, if the chief complaint was breathlessness, then start with the cardiovascular respiratory system first. Always remember the soda scares or secrets mnemonic when dealing with each positive symptoms. Cardiovascular and respiratory system is 1. So you check on breathlessness or dyspnea, you Socratize it. Just uncomfortable awareness, rapid or difficult breathing. The body needs oxygen more than it's getting. So clinical form, exertional dyspnea. Orthopnea, that is dyspnea, develops on lying flat when a patient is lying flat. And how many pillows is the patient using to relieve his dyspnea? Dyspnea at rest, does it become dyspneic or distressing? Kama anavaa nguo anasikia ngumu kuvuta to breathe, as in it's difficult in breathing when you are dressing. Paroxysmal nocturnal dyspnea develop after 30 minutes to 4 hours after getting to sleep. It does not immediately improve upon standing up, unlike orthopnea. So platypnea is another one, is developed on sitting. So platypnea develops on sitting. Don't forget to ask about patients of dyspnea. A patient of dyspnea, how you've been recently on a long flight. Have you been recently on a long flight? No. Exercise tolerance when you're doing this. Check on chest pain, Socratize it, and that is that. So classification of angina or dyspnea, that is classification 1 during initial intensive activity, during ordinary activity, with less than ordinary activities, and at rest. So the one during initial intensive activity, during ordinary activity, with less than ordinary activity, and at rest. So we check that wheeze is a muscle sound occurring. We are going to have all this on in large scale, but as for now, let's just have it an end. And if you have any question, you are free to ask any question. Thank you for presenting or availing yourself up to this far. This clip will proceed from here, but meanwhile this one we are going to post it on our YouTube, so you can follow up and even learn more.